students, I hope I am visible to all and I am audible to all. You will not be able to speak, but you will be able to share your responses in the chat box. So if you have any doubt on the way, you can type your doubt or your question in the chat box, and I will take care of your queries. So first of all, to connect with you, if I'm audible, just type yes in the chat box. Okay, thank you so much. So is my screen visible to all? Sorry, I assume everybody can see the, yes, okay. So welcome to the second webinar of the series of the Biopotentials. And in the previous webinar, we had discussed about the basics of the electrical potentials, the action potential of the excitable tissues, like the action potential of the nerve, the muscle, the skeletal muscle, cardiac muscle, etc. So continuing with the same series, uh, today we'll be discussing more about the electrical activity of the skeletal muscles, which we call as electromyography. Usually in the curriculum of first prof MBBS in physiology, we don't talk much about the electromyography. But in medicine and in the questions from neurology, you were asked about the clinical scenarios in which the EMG pictures are given. So I have gone through some of the previous year questions, in which around 5 to 6 questions they had been asked on EMG. So looking into the requirement of the PG NEET, that what type of questions are asked. So I have prepared a very basic lecture today so that we can cover up the basics of or the physiological basis of the electrical activity, which you would be seeing in the skeletal muscle or the EMG. So first of all, during this session, your learning objectives would be that you should be able, after the end of this webinar, you all should be able to describe the excitation of the muscle and generation of the motor end plate potential. You should be able to differentiate motor end plate potential from the motor unit action potential, and we should be able to describe the characteristics of motor unit action potential and describe the physiological basis of recording of the electromyography. And the most important thing on which the previous year questions they are focusing are the various findings on EMG, which differentiate the neuropathic origin of the muscular weakness from the myopathic origin of the muscular weakness. So to begin, I will start with a motor neuron. So we all know that the muscle is innervated by the motor neuron. So muscle does not contract on its own. It contracts only when it is stimulated by the innervating neuron. So here we also understand that the brain, the motor area, which is there in the cerebral cortex, from there, we have the corticospinal tract, which originates from the cerebral cortex, which descends down in the lateral white column as the lateral corticospinal tract. And this lateral corticospinal tract is formed by the fibers which cross at the level of the medulla oblongata. The uncrossed fibers, they form the anterior corticospinal tract. So now this one thing which I want to focus here is very interesting. You all know that the spinal cord, it has the posterior horn cell and it has the anterior horn cell. The anterior horn cell is primarily the area from where the motor neurons, they originate, right? So now the anterior horn cell, it is divided into three regions: the lateral region, the central region, and the medial region. So as you can see here, the fibers from the lateral corticospinal tract, they end on the neurons originating from the lateral portion of the anterior horn cell, whereas the fibers of the anterior corticospinal tract, they cross to the opposite side and they end on the fibers originating from the central and the medial part of the anterior horn cell. Now, what is the significance of this? Now here, the lateral corticospinal tract, it innervates the lower motor neurons, which innervate the limbs. So hence, the lateral corticospinal tract is concerned with the fine scale movements which are performed by the hands. Whereas the anterior corticospinal tract, it innervates the muscles of the trunk, the diaphragm, the sternocleidomastoid, and hence its main role is to innervate the postural muscles. So with this background, we have now discussed a background of the upper motor neuron, which is formed by the lateral corticospinal tract, the anterior corticospinal tract, and the other extrapyramidal tracts like rubrospinal, etc. So now all these tracts which originate from the cerebral cortex, which end on the spinal cord, they are called as the upper motor neurons. The fibers which originate from the anterior horn cell of the spinal cord and which innervate the various skeletal muscle fibers, they are called as the lower motor neurons. These lower motor neurons are A alpha type, hence they are also called as the alpha motor neurons. Now, each of these, I will just clear out the slide with everything we have discussed till now. So we have seen that each of these nerves, they end on the various muscle fibers. So these muscle fibers, in the center of these muscle fibers, we have that the muscle, it is thrown into the folds, and these folds are called as the junctional folds, or it forms the neuromuscular junction. So it is at this point where the nerve, it sends its signals to the muscle and the muscle gets activated. Now this particular thing, where the nerve meets the muscle, is called as the motor end plate and the potential. So in the last webinar, we had discussed that the voltage fluctuations which appear in a cell, they are referred to as potentials. So now the voltage fluctuation which now appears in the muscle is called as the motor end plate potential, because this voltage is now generated in the motor end plate. And from here, the potential, it is transferred to the length of the muscle fiber. So now, my question here is, what exactly is a motor end plate potential? So I want you to write the answer. I am waiting for a moment here. What exactly is a motor end plate potential? Voltage fluctuation occurring in muscle cells. Yes, we can say. What do you call it in the normal language? Abhi pichle hi webinar mein we had done resting membrane potential of the muscle fiber. So resting membrane potential is okay, but when, yes, that's the answer I wanted. Good, Kirtana. So it is the action potential which appears in the end plate or in the post synaptic membrane, that is the sarcolemma. So here we have the motor end plate potential. So do you recognize this structure? What is this structure? Anyone? So this is a neuromuscular junction, as you can very well see. So I will try pick up a laser pointer. So here you can see this is a nerve which is the alpha motor neuron, and this is the terminal end button of the nerve. All you can see here are the synaptic vesicles. It has the neurotransmitter. What neurotransmitter is here in this synaptic vesicles? What is the neurotransmitter which is present here in the neuromuscular junction? I will be posing many questions alongside. Yes, so the acetylcholine is there in these synaptic vesicles, and it has a lot of mitochondria because mitochondria is required for the immediate release of energy for the resynthesis of acetylcholine. So this is the presynaptic membrane. I will be going a little fast on this because this we had slightly discussed in the previous webinar also. So this is the presynaptic membrane. तो कोई भी अगर अपने पास में junction होता है between two neurons or in the neuromuscular junction, we have a presynaptic terminal. We have a postsynaptic terminal. In this case, the postsynaptic terminal is the sarcolemma or the muscle cell membrane. In case of the synapse, the postsynaptic membrane is another neuron. So here, kindly appreciate these dense bars, and these dense bars are right above the subneural clefts, which have the which are present on the postsynaptic membrane. So now all you can see is that alongside these dense bars, there are the voltage gated calcium channels, and just next to the voltage gated calcium channels there are the release sites from where the synaptic cleft it gets fused and it releases the acetylcholine into the synaptic cleft. So now in the subneural cleft you see there are various receptors which are present here. So here in the neck of the subneural cleft we have the acetylcholine gated sodium channels, whereas in the sac of the subneural clefts, we have the, or we can say deep into the muscle, we have the voltage gated sodium channels. So there are two types of sodium channels which you can see here. One is the acetylcholine gated sodium channels, and the another are the voltage gated sodium channels. So once the action potential it reaches, so once the action potential reaches the postsynaptic membrane, so this depolarizes the, so what happens here? So because of the action potential which reaches here, there is increase in the voltage inside the nerve terminal. So this increases or depolarizes the nerve terminal, which opens the voltage gated calcium channels. So this results in the calcium influx. The calcium moves into the nerve terminal or the presynaptic membrane. So this activates the calcium calmodulin protein kinase. So now these vesicles, they are not just present in the presynaptic terminal. These vesicles, they are held to the cytoskeleton with the help of a protein which is called as synapsin. So what happens, ये जो calcium calmodulin protein kinase है, ये synapsin का phosphorylation करता है और इस vesicle को cytoskeleton से free करता है. So when it gets freed, this vesicle, it moves towards the docking site and it results in the docking and it fuses with the presynaptic membrane. So for fusion of the synaptic vesicles, we have two types of snare proteins. One is the vesicular snare protein, which is called as synaptobrevin, and the other is the terminal, we have this snare protein or the T snare protein, which is syntaxin, which is bound together by a snap protein. So now this is another MCQ here, which can be asked. Now we have a lot of MCQs here. The first is, what is the role of this protein? This synapsin, it binds the synaptic vesicles to the cytoskeleton. And then we have the MCQ, which can be asked on the snare proteins. So we have two types of snare proteins. One is the vesicular snare protein, जिसको हम V से denote करते हैं, and it is the V snare protein, and this is synaptobrevin. Another is the T snare protein, जो कि terminal snare protein के नाम से भी जानी जाती है. And the terminal or the T snare protein, it is syntaxin. So in dono proteins, both of these proteins, they have to be, present and active for the docking to take place and for the release of the neurotransmitter. So in case any of these proteins is not available for binding, in that case, the docking will not take place and the neurotransmitter will not be released. As you will see that this synaptobrevin is blocked by a toxin which is called as the botulin. So botulin, it blocks the synaptobrevin, hence causes muscular paralysis. So with that, we would see that the action potential of the nerve, it gets translated to the motor end plate potential, which gives the action potential in the skeletal muscle. So till this point, we had discussed in our previous webinar. So moving forward from here, now what happens? Now once the muscle is activated, it is going to give you action potential. But do you remember that if the, we can say if the stimulation is not enough to reach the threshold, what will happen? Will it be propagated or will it just die out there? So any guesses? What will happen if the stimulus is less than threshold? My question. So another way, if I have to ask this question, propagation stops. So do you think about something which is if the stimulation or only a few acetylcholine synaptic vesicles, they have released the neurotransmitter, which is not enough to cause the action potential, what will happen? It won't propagate. Local potentials. Now that is the response I want, local potential, and that in terms of the muscle, we call it as the miniature end plate potentials. So now miniature end plate potentials are somewhat like the local potentials which you see in the receptors or in the nerves. And because the neuromuscular junction is also called as the end plate. Right. So all the potentials which are generated in the end plate, they are called as the end plate potentials. So if a little amount of, or we can say less number of synaptic vesicles, they fuse, it is called as the miniature end plate potential. But if a full-fledged action potential is generated, in that case, it is called as the motor end plate potential, right? But we all know that it is not a single nerve or a single muscle fiber which is stimulated. It is actually a motor unit which is stimulated. Hence, the potential which is generated here is slightly different from the motor end plate potential. This action potential is called as the motor unit action potential. Now, a big question comes, what is the difference between a motor unit action potential and the motor end plate potential? So before we go into the nitty-gritties of all this, we should discuss what a motor unit is and what are the properties of motor unit. So here we all know that this is the cell body of a lower motor neuron. Where is this cell body located? My first question. Where is the cell body of the motor unit located? Anterior gray horn. Very good. So the cell body of this lower motor neuron is located in the anterior gray horn. And what type of neuron is this? We discussed it in the beginning of this webinar. What is the type of this neuron? A alpha type of neuron. So this is a multipolar A alpha type of neuron which originates from the anterior horn cell, and it is a myelinated neuron, right? and it has many branches. Here I have shown 4 only, but there are many branches which supplies many muscle fibers. So by definition, a motor unit is the A alpha motor neuron with all its branches and muscle fibers innervated by it. So a motor unit is a bigger thing as compared to the skeletal muscle. So here we are talking about if one neuron is stimulated, it is going to excite many muscle fibers, means one motor unit, right? So if you excite many motor units together, you will get a whole bunch of, or we can say a whole sizable action potential, which is the action potential of the bulk of the muscle. So now what are the various properties of this action potential? The first property is the asynchronous discharge. So we all know that there are thousands of motor units present in which are arising from the anterior horn cell. So now all these motor units, they do not fire at the same time. They fire at different times so that uh, the muscle, sorry, so that the muscle is not it's giving us a sub-technique, but yet smooth contraction. So if you understand, if there is, what is a sub-technique contraction? That the muscle is contracting and relaxing, but this contraction is not smooth, right? So if one motor unit is stimulated, it fires in a subtechnic way. The muscle, the resultant contraction will be contraction and relaxation, but it is not going to be a smooth contraction. So immediately, the second motor unit will be firing, which is going to, or firing after a slight delay, means asynchronously, giving the contraction and relaxation just after a small delay. Then we have the third motor unit, which will again give a similar subtechnic contraction. And then we have the fourth motor unit. So you can see that the resultant muscle contraction becomes smooth as the number of motor units recruited, they are asynchronously discharging. Now think about what will happen if thousands of motor units, they are giving out this asynchronous discharge. So the resultant movement of the skeletal muscle becomes smooth, yet the muscle will not be getting fatigued easily. Think of a cramp. जब कभी cramp पड़ता है, so the entire muscle goes into a simultaneous synchronous contraction. So जो cramp आया है थोड़ी देर के लिए भी, it is very painful because it occludes the blood supply. पर लेकिन जब आप कोई चीज उठाते हो या कोई काम कर रहे हो, जब मसल कॉन्ट्रैक्ट करती है, that is not painful. Why? Because the motor units are discharging asynchronously and it is relaxing in between. तो ये जो हमारी कॉन्ट्रैक्शन रिलैक्सेशन सब टेक्निक कंट्रैक्शन हो रही है, इसमें मसल रिलैक्स जब कर रही है तो उसमें ब्लड सप्लाई आ रहा है, उसके वेस्ट प्रोडक्ट्स बाहर जा रहे हैं. So it gives the space to the muscle for replenishing its nutrients and eliminating the waste products. So इससे हमारे पास में we get a subtechnic contraction which is smooth. Now this is one of the properties of the motor unit, that it discharges asynchronously. Now the second property of the motor unit is recruitment, or it results in the grading of power. Now think about that you have to lift a pen. एक पेन लिफ्ट करने के लिए हमें कम पावर चाहिए, तो हमारे पास में कम मोटर यूनिट्स रिक्रूट होंगी and you will have a better response. But if you have to lift a bag, you will require more power. And how will you get this power? More number of motor units will fire in this and more muscle fibers will contract, and you can grade the power, or we can say the CNS actually grades the power, and this results in the better response by increasing the power, or we can say there is more recruitment of the motor units. So this is one of the properties. Then one very important property of the motor unit is the size principle. So we have the motor units which have the the nerve fibers with smaller diameters, and we have the motor units with nerve fibers with the larger diameters. So when we stimulate initially the fibers with smaller diameters, and they will contract first, and they would result in the contraction of all the muscle fibers which is stimulated or which is innervated by this motor unit. If we require more power, then the fibers with larger diameter will be stimulated, and more number of muscle fibers will be recruited into this. Now, this is called as the size principle. And one thing is very interesting. हम अभी तक पढ़ते आए हैं that the action potential it follows the all or none law. मतलब कि एक बार threshold आया so it will be generated to its maximum potential. But if the threshold is not there, there will not be any response. So this is called as all or none law. But the motor unit does not follow the all or none law. Because the motor units, they will be recruited. But a single motor unit will follow all or none law. So इसका मतलब ये है कि एक मोटर यूनिट अगर स्टिमुलेट होगी तो उसके सारे फाइबर्स स्टिमुलेट होंगे, लेकिन जब हम रिक्रूटमेंट की बात करते हैं, जब हम साइज प्रिंसिपल की बात करते हैं, मल्टीपल मोटर यूनिट्स दे डू नॉट शो दी ऑल और नन लॉ, राइट. सो अगर हम बात करें स्केलेटल मसल एज अ होल, इट विल नॉट फॉलो दी ऑल और नन लॉ, बट अ सिंगल मोटर यूनिट विल फॉलो दी all or none law. So what is the basic principle behind the electromyography, और हमें ये electromyography क्यों करनी है, कब करनी है? So electromyography is nothing but the study of this motor unit action potential in the muscle. So here किसी भी electrical recording के लिए हमें चाहिए होते हैं electrode, wires and a signal processing unit and an output device जो हमें वो signal दिखाए. So here there are two techniques by which we can find out or do the study. The first is a very, very simple technique which is called as the surface EMG. This is not very accurate, but yes, it gives the reasonable results. Another is the needle EMG. So the surface EMG के अंदर में, if this is the muscle, the electrodes, they are placed on the surface of the limb. For example, I have to do the surface EMG of my limbs. So सबसे easy है, हम करते हैं हाथ में. So right, we place the electrode here on the top of the muscle. बाहर ही हमने disc electrodes होते हैं, उसको हम एक conducting paste लेके यहाँ लगा देते हैं, and we connect this with the wire to the recording device, and we record the surface EMG. Now, because since it is recording the signals from the surface, it is not very accurate. The accurate thing would be if I insert the needle into the belly of the muscle, right? So we insert a needle into the belly of the muscle and we record the EMG through that needle. So that will be called as the needle EMG. Okay. So let me clear out this. So what are the various techniques? Please write down. Let's have a quick recap. What are the two techniques by which we can record the electromyography? Quickly type it on the chat box. Surface and needle EMG. So this makes up for your one MCQ. Which is the most accurate out of these two? Yes, needle EMG is more accurate as compared to the surface EMG. So now coming to the electrodes, we have discussed कि अगर हम बात करते हैं Sorry. So if we talk about the electrodes, in case of the surface EMG, the electrodes are disc shaped, whereas in the needle EMG, so I will be focusing on the needle EMG here. So it is like a typical needle which we have, जैसी अपनी injectable needle होती है. This comes as a normal electrode, अलग से packed आता है. It has a bevel. So इस तरीके से इसमें bevel है. एंड सेंटर में इसके एक छोटा सा सेकेंड इलेक्ट्रोड रहता है. राइट. सो दिस इलेक्ट्रोड अगर आप देखोगे इसको यहां से कट करके अगर हम ये देखें, सो इट इज लाइक अ कंसेंट्रिक थिंग एंड अ सेंटर में दूसरा इलेक्ट्रोड है. सो ये अपने आप में ही एक फील्ड बन रहा है विच इज मेकिंग अप दी. so this forms the positive and negative electrode both in a single needle. राइट. सो इस नीडल को अगर हम कट सेक्शन देखें हाथ का या कहीं का भी, तो अपनी मसल्स अगर यहाँ पड़ी हैं, फॉर एग्जांपल दिस इज द मसल, दिस इज द बोन. सो इस नीडल को हमें मसल में पहुंचाना है. सो वी हैव टू पियर्स थ्रू द स्किन एंड द नीडल गोज इनटू द बेली ऑफ द मसल. दिस इज स्लाइटली पेनफुल फॉर द पेशेंट. तो यूजली पेशेंट्स इसमें कोऑपरेट नहीं करते हैं, तो उनको अगर जरूरी है तो वो दिस बिकम्स अ लिटिल टीडियस फॉर द पेशेंट्स, क्योंकि आप कितनी बार उसको नीडल को चुभोने वाले हो. तो इस करके यू हैव टू बी वेरी वेरी पेशेंट एंड काउंसलिंग द पेशेंट फॉर द सेम. राइट. Now the procedure here is that under all the aseptic precautions आपने लिया, साफ किया, उससे पहले काउंसल किया पेशेंट को अच्छे से, अपने बताया पेशेंट को कि आप इसमें नीडल डालोगे एंड इट कैन हर्ट, जैसे एक नीडल का होता है. सो यू हैव मेड ऑल द कनेक्शंस जो भी आपके सेटअप में है, and then you put the needle at the belly of the muscle near the neuromuscular junction. Right. So शुरू में when the muscle is inactive, there is you record. ठीक है. जो सीधा इंसर्ट करते हैं तो आपके पास में सबसे पहले इंसर्शनल एक्टिविटी आती है. मैं अभी पहले बता रही हूँ, बाद में वी विल सी इट ऑन दी पीपीटी ऑल्सो. सो जब नीडल इंसर्ट करते हैं तो वो मेटल का नीडल जब अंदर जाता है तो वो मोटर एंड प्लेट्स को थोड़ा डीपोलराइज करता है, स्टिमुलेट करता है, विच रिजल्ट्स इन स्लाइट इलेक्ट्रिकल एक्टिविटी इन द मसल विच इज कॉल्ड एज द इंसर्शनल एक्टिविटी. उसके बाद में you will not see any activity in the muscle. Now that is called as the spontaneous activity, कि बिना स्टिमुलेशन के अगर हम मसल को स्टिमुलेट नहीं कर रहे हैं तो जो एक्टिविटी मसल से हम पिकअप कर रहे हैं दैट इज कॉल्ड एज द स्पॉन्टेनियस एक्टिविटी. सो अभी तक हमने दो एक्टिविटीज के बारे में पढ़ा है. वन इज इंसर्शनल एक्टिविटी, सेकेंड इज द स्पॉन्टेनियस एक्टिविटी. फिर हम पेशेंट को बोलते हैं टू एक्टिवली कॉन्ट्रैक्ट द मसल. राइट. So when the patient actively contracts the muscle, so now here the contraction is happening against gravity. ठीक है. So less number of motor units will be recruited here. But once I give the resistance, here more number of motor units will be recruited. तो सबसे पहले हम मरीज को बोलते हैं कि आप नॉर्मल जैसे करते हो अपने आप उसको कॉन्ट्रैक्ट करो. तो जब पेशेंट कॉन्ट्रैक्ट कर रहा है, अब यहाँ पर क्या हो रहा है कि you will get the motor activity will be generated, motor unit action potentials will be generated, which you will record. And then recruitment देखने के लिए हम यहाँ resistance देंगे. तो this will be a common protocol for all the muscles जहाँ का भी आपने करना है. I'm just giving you example from here. So here, now let's see what happens next. So this is the belly of the muscle. You can see here. The belly of the muscle, we have inserted a needle here. It is connected to the amplifiers and you record the motor unit action potential. So what you do is, जब हम करते हैं, the first step is connection सब कर लिए. Second is clean the area जहां पर भी आपको टेस्ट करना है. And then you insert the needle perpendicularly into the belly of the muscle. That is all. आपको थोड़ा बहुत एडजस्ट करना पड़ सकता है to get the very good motor unit action potential. So what do you see? So जब हम needle insert कर रहे हैं तब आती है हमारे पास में what is this? We get the insertional activity. So here you can see is कि यहाँ पर कोई भी activity recorded नहीं है. So this is the spontaneous activity. So when we insert the needle, the needle depolarizes the muscle at the end plate, and this results in certain spike potentials, and this is called as the insertional activity. So in between here you can see there is no activity, and this is called as the spontaneous activity. So a healthy muscle ke andar mein there is no spontaneous activity, right? So लेकिन इंसर्शनल एक्टिविटी जो है, जो नीडल के इंसर्ट करने की वजह से आ रही है, दैट इज नॉर्मल, राइट? स्पॉन्टेनियस एक्टिविटी, अब अपने पास में ये मसल है, ये उसका एंड प्लेट है, राइट? ये उसका टर्मिनल है. So the spontaneous activity can be present at the end plate, which is called as the end plate noise, or the end plate spikes. But along this muscle, there is no spontaneous activity. So I am taking a pause here. How will we get the certificate for the webinar? Because in the previous webinar, I have not received. Beta, ये बात हम बाद में कर सकते थे, और you could write to the hosts, right? In between the webinar, I don't want this type of questions. Let's focus here. Okay. So now, what are the various type of spontaneous activities which can be recorded from the end plate potential? So first, you will see the miniature end plate potential because of the fusion of few synaptic vesicles. It can result in miniature end plate potential. So now this spontaneous activity का मतलब है बच्चे के this activity is a natural activity without any stimulation जो कि वहां हो रही है. So end plate पर spontaneous activity, okay, in English, fine. So the spontaneous activity is the one which happens without any prior stimulation, right? So if the synaptic vesicles, they keep on fusing, and only a few synaptic vesicles they fuse and they release its neurotransmitter. So this type of this spontaneous activity at end plate is called as miniature end plate potential. Once the synaptic vesicles they fuse to a level which results in the full-fledged action potential or a spike potential, so you get a muscle fiber action potential. And if multiple muscle fibers they are getting activated, it may give us a multiple muscle fiber action potential which can be linked together. But if you are getting the motor unit action potential because of the stimulation of the entire motor unit, you are going to get a motor unit action potential. So now, motor unit action potential, here you can see the diagram. I've taken this diagram from Preston and Shapiro, which is a very good book on EMG. So here you can see that one motor unit, it is supplying many muscle fibers. So all these are the muscle fibers. So you can see here. So it is giving one motor unit action potential. Please note that a typical motor end plate potential was having a biphasic action potential, means there was one positive spike and one negative hyperpolarization. This is what you were making in your action potential of the muscle, which we call it as the motor end plate potential, right? Or the muscle fiber end plate potential. Okay. Here, the motor unit action potential is a triphasic action potential where you have one negative, second is positive, and then third is again negative. So you get three peaks here. So anytime it crosses the baseline, you mark it as the first point or the first site of the duration. And then you get here the second point. So this marks the duration of the action potential. The amplitude is marked from peak to peak. So this gives us the amplitude from the highest to the lowest peak. So if I tell you to differentiate between the motor unit action potential and the muscle action potential, so we have the duration here. We have the voltage here for the, now this is for the motor end plate potential or the skeletal muscle action potential. And we have the motor unit action potential, which is a triphasic action potential. Could you please differentiate between these two action potentials? Here, I will take a slight pause and I'm waiting for your responses. Let's differentiate. Is there any difference? What is the origin of these two? Let me guide you through the differences. What is the origin of these two? What is the origin of the motor end plate potential and what is the origin of the MUAP? Because it's important to understand that both these are PQRS nahi hai. Okay, so here it is the so in A, I will call it as A, this as B. So A ka origin is from the muscle fiber, whereas B ka origin is from the motor unit. Okay, fine. So A is for a single muscle fiber, whereas B, MUAP, is a single nerve with multiple muscle fibers. Yes, it is related to all or none. Definitely, one motor unit is yes, all or none. But when we talk about the different motor units, when we talk about the muscle as whole, then it doesn't follow the all or none principle because the motor units keep on recruiting. Each motor unit follows all or none principle, but the skeletal muscle, which is a blend of many motor units, does not follow all or none law. Okay, I have certain MUAP, nature of stimulus is sub-threshold, AP is supra-threshold. No, both of them would require the threshold stimulation for the nerve, right? So here in the motor end plate potential, let me now again. So if I have this neuron and it has multiple axon terminals. So it has one fiber here. So now let me change the color of the pen for a better understanding. So if I stimulate, if I record the action potential from only one part, I will get the motor end plate potential. But if I record the potential from all these together, I am going to get a motor unit action potential. I hope I'm clear in making this. I could tell you that what is the difference between motor end plate potential and MUAP. So when we are recording the action potential from a single nerve terminal and the muscle, it is the motor end plate potential. But when we are recording it from the whole motor unit, so it will be all the nerve terminals and all the nerve fibers, it will be MUAP, motor unit action potential. So that is why it has three phases, right? So here also the motor unit action potential, it has the duration depends on the number of fibers which are getting activated, right? And the amplitude doesn't matter much here in the motor unit action potential because all the fibers are not very close to the needle which you are inserting. Some of the fibers which are very close to the needle while you are inserting it in the muscle fiber, they will constitute the amplitude here, right? So it is the duration which is important. A motor unit with more number of muscle fibers will have a broader duration, and in some of the cases, this is the very simple type of motor unit action potential. The motor unit action potentials could be also recorded as serrations and this. So that shows us that more number of fibers are there, and this type of motor unit action potential is also called as the polyphasic motor unit action potential. We'll talk about it in a coming slide. So we have discussed that the spontaneous activity in a normal muscle is zero. There is no spontaneous activity. But what if there is a spontaneous activity occurring? What kind of spontaneous activity can occur? So now I'll give you a scenario. Don't read what I am given on the slide. Just think of a scenario. There is a patient with a nerve damage. So what happens? Let's take up a whiteboard. If can I take a whiteboard here? No, I don't have the whiteboard here. So I can
Ma'am, you
open
can
up
go
my,
to the more section on the right side corner lower at the screen, and there you will see the whiteboard option.
ये कुछ issue हुआ है इसमें. What have I done? नहीं, इसमें मोर में नहीं है. ट्रांसक्रिप्ट है, रिमोट है, फ्लोटिंग विंडोज है.
Yeah.
I cannot see.
It's just give me a minute, ma'am.
I want to close this. ये Cortana शुरू हो गई है नीचे.
Ma'am, maybe try now. I've made you the co-host.
नहीं.
Okay.
It's okay.
I'll check about this, ma'am, again.
I would. I'll use this
Sure, ma'am.
point. I'll clear this. I'll use this slide. I'll use this slide to show you. So kids, remember that all the muscles, they will get stimulated only when they get the uh, command from the neurons, right? From the nerves. So for any muscular disease, what are the three steps or what are the three things that could be involved for the muscular weakness? So the first is if there is a problem in the nerve, so you will have the neuropathic cause of the muscle weakness, right? Or there is a problem in the neuromuscular junction. So you have the neuromuscular junction related muscular weakness. The third is the muscle itself is damaged, which is called as the myopathic cause of the muscle weakness. So the muscle weakness can occur because of three reasons. One is there is the problem in the nerves. Now, what type of problem can occur in the nerves? One is that this nerve is injured or it is cut. This is damage. There is axon loss. So there is decrease in the number of axons which can occur in the injury. Or there is loss of the myelin sheath. ये जो myelin sheath है, अब इसका loss हो गया. So the second problem which can occur in the neuropathic is the demyelination. Right? So let's talk about the injury to the nerve fiber. So what will happen if there is injury to the nerve fiber and the muscle is denervated, right? You understand the meaning of denervation? So denervation means that the muscle is not supplying, it's not receiving the nerve supply. Now, what will happen to the muscle if it is not receiving the nerve supply? Yes, somebody has raised the hand. You can type your question, bache. You can type your question in the chat box. I will answer. So what will happen if the muscle is denervated? So if the muscle is denervated, it will not get the stimulus from the nerve to get contracted, right? So in that case, the muscle will in the need of the command, because when the muscle loses its command center, it increases its receptors, right? So there is something which is called as denervation hypersensitivity. What is denervation hypersensitivity? So whenever the muscle is denervated, matlab nerve supply, if it is cut, so what will happen? There is decrease in the stimulation of the muscle, or there is decrease in the neurotransmitter, there is decrease in the acetylcholine which is being secreted. Now, whenever there is decrease, the muscle is not getting the neurotransmitter, so there is upregulation of the receptor. So there is increase in the number of receptors. Which receptors? The acetylcholine gated sodium channels. So now the number of these receptors that will increase. So whenever there is slight acetylcholine which is secreted on anywhere, it is trying to grab that acetylcholine and will try to give some response. Now this some response is going to appear as the spontaneous depolarization of muscle due to active denervation. So here what you see is this type of potentials, they appear, and this spontaneous activity is called as fibrillation. I hope I am able to explain fibrillation to you. If you are getting it, please type yes. Okay. So the fibrillation will be seen if the problem is with the nerve. There is denervation, there is upregulation of receptor, and this results in spontaneous depolarization of the muscle. And you would feel that if the nerve if the muscle is denervated, there would be spontaneous twitching of the muscle now and then. So that is called as denervation hypersensitivity. One question. This is again one of the questions which you may come across. Now also appreciate that there is no activity here, right? But what you see here is a sudden spike potential, which you may see. Now this is the fibrillation potential. So you would see sudden spikes here and there, which are called as the fibrillation potentials. Now, the another thing is the fasciculation potential. If the nerve is there, but there is weakness of the muscle. So now, the muscle, it just gives you brief twitches, right? And this may result in the movement. And this is again associated with the lower motor neuron disease, especially with the amyotrophic lateral sclerosis. So now when there is anterior horn demyelination is there, or the anterior horn is damaged, in that case also there would be brief twitches or the fasciculations of the muscles which could be recorded. So in which condition you will record fasciculation? In which condition you will not record fasciculation? You will record it in the lower motor neuron disease on EMG, right? Oh, I had it here. So now let me take a small quiz. Identify one. What type of lesion here could lead to EMG changes? What is one? A small quiz. Lower motor neuron lesion. So can we say that I want to ask you what type of lesion in the neurons could lead to EMG changes? What EMG changes? I am coming to it next. One is demyelination. Second is axonal loss, right? Or the injury to the nerve. So we have two type of lesions which could be there here. One is axonal loss, means injury to the nerve. Axon is lost, right? Or there could be demyelinating injuries. What is two? What is 2? Name, could you please name various NMJ? Okay, yes, I got it. Myasthenia gravis. Any other disease you know about the neuromuscular junction? Lambert-Eaton, very good. Have you come across anything in the third thing? I mean, yes, botulinum again, but botulinum is a transient paralysis. You will not do EMG for botulinum toxin. Duchenne's, very good. Duchenne's muscular dystrophy, Becker's dystrophy, but yes, Duchenne's is there. So any type of muscular dystrophy where the muscle is damaged is your muscular cause. That is the myopathic cause. So now when we talk about the motor unit action potential, what you all need to know is that when we study now, we have a patient of muscular weakness. So a patient with the lesions of motor neuron, lesions of neuromuscular junction, lesions of the muscles, they can present with the muscular weakness. Now you have a patient of muscular weakness and you are doing an electrodiagnostic study on, right? So what in electrodiagnostics you would do to confirm your diagnosis, whether it is neuropathic, myopathic, or the neuromuscular junction? So only EMG is not sufficient to diagnose the neuromuscular lesions. So we need to do the conduction studies. So the conduction studies are done on the nerves. There are two types of conduction studies we do. One is the motor nerve conduction studies, in which we find out the nerve conduction velocity, we find out the nerve conduction amplitude, right? So motor nerve conduction studies. Here, since we are talking about the neuromuscular aspect only, so I am not currently dealing with SNAP, that is sensory nerve action potential, but definitely that can also be added to electrodiagnostic studies, because most of our nerves are mixed nerves. They have the motor as well as the sensory neurons. So we have the motor nerve conduction studies, the SNAP, the sensory nerve conduction studies, and then there are something which is called as the repetitive nerve stimulation. अभी सिर्फ आप नाम इसके एक बार just get familiar with the names. I will tell you what all of these mean. And in the end, we will be doing the electromyography for these nerves or in these areas for the which we are performing the study. So now, when we do the electromyography, which is our current topic, we study the morphology of the motor unit action potential. Morphology means the shape of the motor unit action potentials. So we record many motor unit action potential while we ask now we have in the procedure we discussed that we will insert the needle, we will ask the person to do an active contraction of that muscle, and then we will also put some resistance and the patient has to contract against resistance. So now what we see is, let me show you a normal interference pattern. So a normal pattern with in this A, you can see this is the normal interference pattern. So this is the normal pattern in which the EMG is recorded. So when the person is contracting with the needle inside, so we are recording multiple spikes, right? So each of these spikes will have good amount of MUAPs, right? So here multiple MUAPs are overlapping and hence you are getting this interference pattern. So now here you can see that the amplitude is also very well, you can see that the spikes are very well demarcated here, and we take good clear 20 MUAPs, and we do an average out of these 20 MUAPs, which are plotted on the graph, and but the software does it all, and it gives us a combined MUAP. A good MUAP looks like a triphasic action potential, which has one major spike and it has multiple serrations. Now, these serrations are obtained because of the contraction of the other muscle fibers which are there in the motor unit potential. And so the duration of this MUAP is around. So this would be seen when the person is actively contracting, not at the spike end plate spike. So the one which we had seen earlier was an end plate spike. Here, this is seen from the motor unit action potential when the person is recruiting, right? So this is the normal morphology of the action potential. Then we see the recruitment pattern. So what will happen in the recruitment pattern is these uh, these spikes which you are getting, they will get intensified. The the amplitude will become larger. They will come more closer, and it will become more intense. So that shows that more number of motor units are now recruited for this particular activity. So now this tells us that a EMG is apparently normal. But for a neuropathic cause, only EMG is not sufficient. In that case, we have to add up the nerve conduction studies along with the EMG to find out whether there is the axonal loss or the demyelinating type of lesion which is seen in the patient. So now quickly going through, I have summed up it broadly for you so that you are able to answer your PG NEET questions. Though this topic is super broad, I can talk about almost a week on neuropathic and myopathic lesions. But for you, you just have to take home one-liner messages, which will help you in answering your MCQs. So now, as we have discussed, that there are two type of lesions in the neuropathic muscle weakness. One is the axonal loss, that is loss of the nerves or the axons. Another is the demyelinating. So in axonal loss, the MUAP in both the neuropathic lesions, whether it is axonal loss or demyelinating lesions, the MUAP morphology will remain same. It will be normal. This means once the nerve is able to stimulate the muscle, the motor unit action potential will be normal because the muscle is normal. So the motor unit action potential would be normal here. It may even be increased, or the muscle will be trying to compensate, right? And the recruitment is reduced. The nerve, the motor unit जो आपकी है, this motor unit is not able to, because there is axonal loss, right? You now take my point. So when there is axonal loss, so we have, where is the pen? Okay. So if this is one neuron and these are all this is the motor unit, this is the second motor unit. Now, if this third motor unit, which was supplying the muscles, this is damaged. Now, the motor unit 1 and 2 will be doing the recruitment. The fibers which were to be recruited by this motor unit 3 will not be able to recruit. So, when the person is trying to contract against resistance, or the person needs more power, he is not able to generate more power. Hence, the recruitment is affected in a patient with neuropathic muscular weakness. Is it clear? I'm just giving a pause here so that you assimilate this knowledge that the morphology will remain normal, but the recruitment is reduced in the neuropathic origin of the muscular weakness. If it is clear, write it's clear in the chat box, then I will move further. If it is not, then I will speak again. Okay, done. Now, as I have told you, in neuropathic lesions, we have to do the conduction velocity also. In axonal loss, the conduction velocity will remain same, though the amplitude of the voltage may become less, but it will be still transmitted to the muscle, right? But in demyelination, so now what is the difference between the conduction velocity of a myelinated nerve fiber and an unmyelinated nerve fiber? Which will conduct faster, myelinated or unmyelinated? Myelinated, right? So if a motor neuron, which is actually myelinated, it becomes demyelinated. Now, what will happen to the conduction speed? It will slow down, and hence a slow conduction with reduced recruitment. What is the diagnosis? A slow conduction with reduced recruitment. What type of muscle weakness? What is the origin of this muscle weakness? Neuropathic. Very, very clear. Neuropathic में what type? Axonal loss या demyelinating? Perfect. So you got that correct, right? Now moving on to the myopathic uh, cause of the muscular weakness. So now when the muscle is weak, it is getting stimulated properly. The nerve is good. The neuromuscular junction is good. But when it comes to the muscle, when it tries to contract, in that time, the motor unit action potential is not strong enough. I told you that the duration of the motor unit, the action potential. Now, this duration of the motor unit action potential, it depends on the number of muscle fibers which are getting stimulated. So, if the number of muscle fibers they are less, so their duration will be short, and this amplitude is going to be small because of less number of muscle fibers they are getting stimulated, and it is going to be a polyphasic. Again, you will get multiple phases of the action potential, and you may even get a small satellite potential. So this is what you would see, sorry, in the myopathic morphology. Here, the recruitment is normal. Isn't it amazing that the number of muscle fibers which are contracting are less, but the recruitment remains normal? So what happens here is that when the nerve stimulates, there are less soldiers on front. Less number of muscle fibers are there. So in an attempt to perform better, more number of motor units they get recruited at the same time. That is why it is termed as early recruitment. So apparently it appears that the recruitment is normal in the early myopathic diseases. Even in the chronic myopathic origin of the muscle weakness, the recruitment may be normal, but in the end stage myopathic disease, the recruitment finally decreases. Is it clear, this thing, that why recruitment is normal in the myopathic lesions? If it is clear, please write clear. If it is not, I may come again. Okay. So now here, since the neuropathic cause is normal, the conduction velocity would remain normal. I hope you would, by using this table, you would be able to differentiate between the neuropathic and the myopathic origin of the muscular weakness. So here, if you see, the graph A shows us a normal EMG response And graph B shows us the neuropathic origin of the muscle weakness. Here you can see that the morphology of the motor unit action potentials, it remains apparently normal. Even the amplitude appears to be larger as compared to the normal graph which you had been seeing, but the recruitment is less. You can see less number of motor units getting activated. So you can see a lot of space in between. So this shows us that less number of motor units are getting activated. So this is a typical graph or a typical recording you will have in a neuropathic lesion. While in a myopathic origin of muscular weakness, now here you see that it appears polyphasic and the amplitude is small. The duration, though it doesn't appear, it is not visible here. But once we will expand this, we will just open this up, you will see that the duration is also decreased. It is different as compared to the normal EMG graph. Now, the take-home message. Now, you have to remember certain points. These points have been jotted down from your previous year questions. That EMG, the utility of EMG is to differentiate between the neuropathic and myopathic disorders. And in neuropathic, you will need to substantiate with the electrodiagnostic studies. The motor unit recruitment pattern is assessed in EMG to evaluate the muscle function. The fibrillation potentials, they are indicative of denervation, especially seen in the LMN lesions, whereas the fasciculation potentials are again in the motor neuron disease. The MUAP morphology is prolonged in neuropathy and short duration in myopathy. The insertional activity is normally seen when you insert the needle, and it is the muscle becomes hyper responsive in case of early denervation, and it is decreased in chronic atrophy. The size principle says that the smaller motor units, they get activated first, and then the larger motor units are activated. The neuropathic EMG findings, they show the large polyphasic MUAPs with decreased recruitment, and the myopathic EMG findings, they have the small short duration MUAPs with early recruitment. The end plate noise or spikes are seen with needle insertion, and they are abnormal if they are persistent. Spontaneous activity in EMG is not seen in normal muscle. If it present, it indicates a disease process. The electrodiagnostic tests are EMG plus nerve conduction studies taken together, and abnormal MUAPs are seen in motor neuron disease, radiculopathies, and myopathies. What is a radiculopathy? Radiculopathy is when the root is originating from the anterior horn cell. So that sensory and the motor roots which are coming out and going into the spinal cord, they are called as radicals. And any disease process, compression or demyelination of that area is called as the radiculopathy. The muscle fiber action potentials are the basis for detecting the muscle pathology in EMG. And what are the various clinical applications? They are used in amyotrophic lateral sclerosis, the myopathies, radiculopathies, and nerve injuries. Now it is the quiz time. Mansi is going to share couple of questions with you from the last year questions. Let's see how many of you can answer that. Mansi, please share the poll. The first question is, which of the following best describes the electromyography? Bache, your certification depends on your responses in the poll. Those who will respond in the poll will get the certificates. We have 5 questions, so please respond quickly. We have 48 participants. All 48 have to answer the poll. The question is displayed on the screen, bache. People are answering the question. We are still on the first question because only 30 students have answered. I think we can move to the next question, please. The answer here is, I will give the answers right away. Which of the following best describes the electromyography? So it is the recording of electrical activity of the skeletal muscle. Choice B is the correct answer. Which type of EMG is used to assess neuromuscular disorder? Surface EMG, intramuscular EMG, evoked EMG, or EEG? Why some people are not able to see the question? I don't know. Beta, maybe you have, I can't say that. Why aren't you seeing? So 50% of people have answered it. Please answer quickly so that we can quickly wind up the session. It's a very, very simple question. The tough ones are ahead of it. So the intramuscular EMG is also called as the needle EMG. So the answer here is intramuscular EMG or needle EMG. Which of the following conditions shows decreased motor unit recruitment with large amplitude, long duration motor unit potentials in EMG? Whether this muscular weakness is myopathic in origin or motor neuron disease or neuropathic or myasthenia gravis. What is the, we just now did this. It's very important and this is from your previous year question. Once we get around 30 responses, we will end the poll and we'll move to the next question. I mean, I'll answer the question. So here, there are two choices which are closely related. This is definitely not a myopathic origin. So you are having, there is a problem with decreased recruitment and there is increased morphology, or we can say large amplitude with low recruitment. So the main reason here is the answer is neuropathic. Motor neuron disease, we will not say probably because it may confuse us with the upper or lower motor neuron lesion. So in upper motor neuron lesion, this is not going to work. It is there only for the lower motor neuron lesion diseases. So the most common or the most appropriate answer here is neuropathy. What is the characteristic finding in EMG for myopathy? So what? Brilliant. Brilliant, brilliant. Small short duration. Yes, motor unit potentials. You are getting it right. Brilliant. So that is the answer. You guys were attentive during the session. Let's move to the last question. EMG is most useful in the diagnosis of which of the following conditions? For myasthenia gravis, we would do the, I did not talk about the myopathy here. Sorry, I did not talk about myasthenia gravis because we would do the repetitive nerve stimulation. That is the diagnostic test for myasthenia gravis. So that shows the decremental potential in the decremental response in myasthenia gravis and incremental in Lambert-Eaton. Multiple sclerosis is a central nervous system disease, demyelinating, involving these multiple nerves. So mostly EMG जब हम solo कर रहे हैं, so that is going to be pinpoint diagnosis for muscular dystrophy, right? So the answer here would be muscular dystrophy. So with that, we can end the poll and we have done all the 5 questions of the quiz. And if you have any questions, you can ask me now. Because with that, we come to an end of the session. If there are any questions from your side, you can raise hand or you can type your question in the chat box. Thank you, Frida. Loved your feedback. Bache, this reference book is too much beyond your scope. Jitna we have done today is more than sufficient for you. I hope these sessions will be available on YouTube soon.